Thank you for joining us today for Signs and Symptoms of a Stroke presentation in honor of National Stroke Awareness Month. My name is Elena Wiesner, and I am the Marketing Manager at McLaren Bay Region. During today's broadcast, if any questions come up, please feel free to comment, and they will be addressed at the end of the presentation. Today, I have the honor of introducing Dr. Brad Blaker, Medical Director of our Emergency Department at McLaren Bay Region. Welcome, Brad.
Thank you so much, Elena. It's a pleasure to be here to talk about stroke during Stroke Awareness Month. Today, we're going to focus on the signs and symptoms of an acute stroke. So when we talk about stroke, important statistics to remember is that stroke is responsible for more deaths annually than AIDS, tuberculosis, and malaria combined. When you look at stroke, one happens every 40 seconds. That's pretty impactful with patients across the board, across the country. Kills 128,000 people a year. That's why it's hugely important for us to focus on. Here at McLaren Bay Region, we are a primary stroke center, and we do participate with the regional stroke network throughout the McLarens with our comprehensive center in Flint. So one of the most important slides I'm going to talk about today is, am I having a stroke? So when we first developed signs and symptoms and good acronyms for people to remember, we came up with the BEFAST acronym. And that's what everybody recognizes. Are they having a facial droop? Is it one of the arms, one of the legs not working? Are you having difficulty with your speech? Maybe it's garbled. Maybe you can't get words out. Maybe it's inappropriate comments when you're asked a question. And then we found that we were missing some of the strokes that happen in the backside of the brain. And so that's where the BE comes from, the balance. I can't walk a straight line. I'm falling. I feel like somebody is pulling me down, as well as trouble seeing with the eyes. The T in the BEFAST acronym stands for terrible headache. This comes more into play when we're dealing with a hemorrhagic or a bleeding stroke versus the blockage stroke, and those two are treated very differently. And then time. It is absolutely crucial to activate the EMS system. If you or anyone that's around you are exhibiting any signs or symptoms of a stroke using this acronym, make sure that you call 911, activate the system. Time is brain. And for us to get to you as quickly as possible is crucial. And all that time that the EMS system provides us really does help streamline the process for you when you present to the emergency department. Each minute, you're going to lose 1.9 million neurons. We have a lot of neurons, but we need every single one of them. And so time is brain tissue, and it's crucial that patients get to us in a timely fashion. The quicker they get to us, the more we can do. Once a patient arrives in the emergency department, whether they're coming in by EMS or whether they're coming in by auto, we activate our stroke response network. That puts a team of experts into play that will rapidly evaluate the patient, determine the best appropriate care moving forward, and we follow algorithms to get patients to the CT and then deliver life-saving medications. Most people remember them as the clot busters when we have a blockage type stroke. This is a copy of what our stroke protocol looks like. Anytime a patient presents, we do activate them as a stroke response in the emergency department. We follow this algorithm, getting them to the CT scanner within 20 minutes. A lot of times they never leave either the wheelchair that they present in or the stretcher that they're brought in by EMS. We'll get them right to the CT scanner. We get the images that we need, and we are on the phone with a board-certified neurointerventionalist to determine the need for clotbuster medication or invasive therapy as it may need if there is a large blockage in the backside of the brain. So some of the things that we look at for goals from the acute ischemic stroke, and this is the blockage type stroke, is getting patients to the CT scanner within 20 minutes. This is crucial. This is what drives the entire process. A stroke is a clinical diagnosis. There's no magic test that I can do that will say you're having a stroke. It's based upon the presentation and everything that's going on with you. And so we get the CT to help drive our care. It helps support what we do for the patient. Are you having a bleed, which is treated very differently than if we're going to give you the clot buster medications? And the stroke response is crucial to activating the entire team. Pages go out to a neurointerventionalist who's on call 24/7. The ER team is notified and at bedside. CT scan, laboratory, and everybody else that needs to be involved are activated with the system to function as one big cohesive unit. The clot buster medication that we use is called TPA, and this is some of the demographics that go around it. And so there are risks with this medication. It definitely does break up clots that may be causing a stroke, but it will also break up clots that may be holding back a bleed somewhere else. And so not everyone that presents with a stroke will get clot buster medications based upon their history, based upon previous surgeries. But if you are a candidate, our goal is to institute this medication gold standard within 30 minutes. Current recommendations are 45 minutes. Last year's recommendations were 60 minutes. So as you can imagine, we're really pushing forward to getting patients to CT scan to determine the appropriate candidates for these clot buster medications, because it really does improve outcomes for our patients. The large vessel occlusion stroke, not a new kid on the block, but it's getting more press when you start looking at these types of strokes. And these are big blockages in the big blood vessels that feed blood into the brain. And if you will, one of the old terms that we used to use for a stroke is a brain attack. Most people will consider that synonymous to a heart attack, but with the brain. And so with the advent of neurointerventionalists and interventional therapy, we will do what's called a drip and ship. So you will come in, you present with a stroke, we obtain the CT scan, you receive the life-altering clot buster medication, and then you will be transferred within 60 minutes to our comprehensive center, where our stroke specialists are waiting to then do what's called a thrombectomy, where they actually go in and remove the clot. This is one of those devices that help removes the clot. It's a mechanical endovascular reperfusion, and it's a basket that they insert within the blood vessels that will encapsulate the clot, close around the clot, and they mechanically remove the clot that's blocking and causing the stroke. This is used in conjunction with the clot buster medications, or it may be used solely when the clot buster medications are not recommended or required. Medical therapy, when it comes to stroke, we will allow patients to remain hypertensive. And hypertensive for me in the emergency department is a little different from everybody else. I will tolerate higher blood pressures in patients as long as their symptoms will support what their blood pressures are. We keep these patients hydrated with IV fluids, as well as we will use antiplatelet therapy to keep the vessel from reoccluding when needed. Hemorrhagic strokes are the bleeding type strokes. And so this is one of the reasons why you probably shouldn't take an aspirin if you get a really terrible headache that's an acute onset. We need you activating the 911 system and coming to the ER for us to do an evaluation, especially if you never had headaches before, and this is the worst headache you've ever had in your life. This is not something to wait on. This is not something to sit at home and see if it gets better. Let me take a couple Tylenol. You can contact your PCP, but I would prefer that you contact 911 and come to the ER and see me so we can get a CAT scan to determine if it is a bleeding stroke or not. This is treated very differently than the blockage type strokes, and there are several different types. We have epidural hematomas, subdural hematomas, where you will get weakened areas in the blood vessels. They rupture. Maybe it's an aneurysm. Maybe it's just a weakened vessel itself. Maybe there's a small growth over the area that's eroding into the blood vessel, and these break open and bleed. And if you've ever seen somebody get cut on their scalp and they get what's called an arterial bleeder, one that pumps blood, it puts out a lot of blood. It can be very dramatic when you see it. Imagine doing this within the skull that can't expand. And so the only place for blood to go is to push the brain and compress, causing a stroke. Symptoms, usually you're going to see an acute onset of a headache that is the worst headache you've ever experienced. People may lose consciousness, they may be altered, and they sometimes will have all of those other or part of those other symptoms that we talked about in the BEFAST algorithm. The key here is the acute onset of the headache. If it's bad, you need to come to the emergency department. Treatment for these could be medical and could be surgical depending on the type of bleed and the severity of the bleed. So here we will monitor the blood pressure and keep it subdued with IV medications. This prevents the bleed from getting bigger with increased pressure in the brain. We will make sure that if you're on a blood thinner, most people know these by their trade names, Xarelto and Eliquis and Plavix and aspirin. We will reverse those if it's appropriate to prevent the bleed from getting bigger. And in certain cases, we will obtain an MRI. The gold standard for these types of strokes, whether it's the blockage type or the bleeding type, is to get the CT scan as well as what we call a CT angiogram. That puts dye into the vessel so we can see exactly where the problem is, where the blockage is, or where the bleeding is coming from. It gives a lot of information to our interventional team if they need to intervene. Surgical treatment for these bleeds. Sometimes they will do operations where they put what we call a bolt in medicine, which is a pressure monitor within the head to determine if the pressure is appropriate. More surgery may be needed if the pressure goes too high. Coiling and clipping, as well as flow restrictors, are the new kids on the block when it comes to managing aneurysms. So if an aneurysm is identified and it's bleeding, they put coiling within that blood vessel to help stop the bleeding. They could clip it, and then they have flow restrictors, which acts like a noose around the aneurysm to decrease the amount of flow that goes through there, stopping the bleed. Again, I can't stress enough, BEFAST. Any loss of balance, any trouble seeing, facial drooping, arms, legs not working, speech is either slurred, inappropriate, or absent, with a terrible headache or without a terrible headache, you should activate the 911 system. During COVID, we've seen a lot of, when COVID first hit, we've seen a lot of patients sitting at home and were afraid to go to the hospitals because of COVID. And what we found is that when the patients finally showed up at the emergency department, they were very, very ill and sick because we didn't have the opportunity to intervene on their disease process. I can't state this enough. The hospitals, the ERs were ready and waiting. So when you develop any of these symptoms, please contact the 911 system, come to the emergency department, and allow us to provide you with that evaluation and the treatment that you need if needed. One of our billboards, again, the paramedics, the 911 system is crucial to what we do. As the EMS, if you call and activate the 911 system, the conventional thought process is that I can get there faster if I just jump in my car or if I have my loved one drive me to the hospital. The issue that we have with that is when you activate the 911 system and the paramedics get on scene, they will call our stroke response from the field. Now, what that does is that mobilizes our team even earlier. Our team is ready and waiting in the emergency department 24 hours a day, 7 days a week. But any additional time that we can obtain is a safety factor for you because brain is preserved the quicker we can provide the treatment. And if you are a candidate for the clot buster medication, we want to do that as quickly as we possibly can. And the EMS system and pre-activation allows that to happen for you. So the minute that you arrive on that stretcher, the team is notified. There's a physician waiting for you at the counter. They do a brief evaluation, and you go right to the CAT scan on the same cot that you were just loaded onto by EMS. It is a very streamlined system, and it really does cut down the time that it takes to give medications when they're needed. Keeping you safe during COVID. Again, I'll do my little COVID plug, even though this is a stroke discussion. Please, 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 I can't stress this enough. If you need to seek emergency care, please seek emergency care at your local emergency department. We've seen a lot of people through COVID sit at home and they continue to get sicker with diseases that we could easily intervene with. The things that we're doing to keep you safe is more frequent cleanings and screenings at the doors, and the staff has been provided with personal protective equipment. We're keeping the patient separated from a COVID suspected or COVID positive to COVID negative patients. And so your hospitals are safe. Please use them as you need to when you develop symptoms. Remember to keep yourself safe at home and in your environment. Wash your hands, wear your mask, and maintain proper social distancing. This is going to diminish the amount of community spread that we see with the COVID virus. That having been said, we're at the question session, so I'll turn it back over to Elena.
So much great information, Dr. Blaker. We have a number of questions that have been submitted, so we will take the time to go through each one. The first one just popped up on the screen is from Grace Burnt. If I think someone is having signs of a stroke, should I have them take a baby aspirin?
So current recommendations, no medications. Activate the 911 system and get them to the emergency department. You could ask the same question about if they're having a bad headache, should I give them an ibuprofen or a Tylenol? Again, this falls along that same line. If a stroke with a baby aspirin or a full strength aspirin, or if you have a terrible headache with Motrin or Tylenol or an aspirin, we would rather evaluate you in the emergency department. Please do not give any medications. We will see you at the emergency department and make that determination there.
That is very important to remember. Thank you. The next question we have is from Laura. If my symptoms go away, should I still get checked out?
Absolutely, you should get checked out. If your symptoms go away, this could be what most people will call the TIA, or the transient ischemic attack. This could be a stroke in evolution. So your symptoms may get better and they may come back. If it's appropriate for you to see your primary care physician, you can. But an evaluation in an emergency department will be crucial to make sure that you are provided the best care at the most appropriate time to prevent a stroke in the future.
All right, great. The next question is from Grace Rodriguez. If I live nearby the hospital, do I still need to call for an ambulance?
The short answer is absolutely yes. The time that we're afforded by activating the EMS system and getting that forewarning as you present to the emergency department is really helpful, and it is beneficial for your treatment as we move through the whole stroke process, whether it's you're going to receive clot buster medications or you're a candidate to go down to the comprehensive center for a thrombectomy where they remove that clot, or we're going to treat you symptomatically, which means that we put you on medications to prevent anything in the future. That really gets the ball rolling. And so no matter if you live a block behind the hospital, please activate the 911 system. It really does help us.
And that is great information. I honestly, before I worked for the hospital, I didn't think about the fact that an ambulance was basically a rolling emergency room. So that is great to know. The next question we have is from Karen Jean Scheib Jacobs. A brainstem infarct survivor with 4 aneurysms still in the middle of cerebellum. Is COVID vaccine still recommended? If so, which brand?
So from a COVID vaccine standpoint, I would defer this to your primary care doctor. They are going to know. So even though you have had the brainstem infarct and you have 4 aneurysms, your primary care doctor is going to have a better feel for your overall medical condition, if you will. Maybe you have diabetes, maybe you have hypertension, maybe you have asthma, or a combination of all of those. And so it's very important to clear this through your primary care physician before you receive the vaccine. As far as which vaccine you should get, the one you can. So I do support everybody being vaccinated. I don't support one vaccine over another. I think that the one that you can get is the one you should get. And follow up with the primary care doc.
All right, great. We have one last question, and this is from Sammy Mitchell. What should you do to reduce your chance of having a stroke? So high level, what would you recommend if you could say one last thing?
All those things that are good for you. Don't smoke, don't drink, and eat a good healthy diet that's low in cholesterol, low in fat. So all those things that lead to a good healthy lifestyle will all help decrease. You can't really help very much genetic predisposition to atherosclerotic plaques or high cholesterol. So you can't do much about those, but living a good, healthy lifestyle puts you on the road to maintaining a good, healthy blood pressure as well as good cholesterol numbers, and will help improve your risk factors for stroke.
Such great information. We can't thank you enough today for sharing your time and knowledge with us, Dr. Blaker. So thank you so much.
It's been my pleasure. Thank you.
Great. All right. And as a reminder to everyone, we have one more virtual presentation in honor of National Stroke Awareness Month. It's going to be on May 26th at 5:30 with Dr. Nasrallah, and he will discuss the risk factors that you can control, treat, and improve in order to reduce your risk of stroke. That's all for us today. Thank you so much for joining us. Take care.